The evolution of integrated primary care at Providence is really an interesting story. The program actually was started by Providence giving some providers to clinics that had requested assistance. So we actually paid for providers to be embedded into clinics, probably I want to say 7-8 years ago, and really began to see that A, that made a good difference, and B, the way we were doing it wasn't really meeting the needs of what we needed to do. So we took the program in-house and began to expand it organically. And I gotta be honest, I don't know that I'd recommend doing it that way. Part of what ended up happening was the program grew very, very quickly. We went from only a few clinics to all of a sudden there's 25, 30 clinics, and there's interns and residents, and there's not a lot of fidelity to any given model. So we have a lot of providers with great intentions being placed everywhere from very urban downtown Portland to very much the kind of specialty neighborhoods of Orenco and Tannisbourne and now Bridgeport, to rural areas like Molalla and Seaside and Hood River. And all of those models are really starting to look very different. Some of those models experimented with having integrated psychiatry for a while. And I got to tell you, I've learned something about integrating psychiatry into primary care, especially through what happened with Providence. When you put a psychiatrist into a primary care clinic, they're kind of like kryptonite and Superman, because amazingly, the providers around them suddenly lose the ability to prescribe any form of psychotropic medication. So we learned a lot from these things. And one of my challenges when I came in was to take this incredibly awesome program and make it better. So when I look at where Providence wants to go with its integrated behavioral health and primary care, our initiatives are to really standardize that care and then remove the barriers to care. We have a lot of barriers at Providence. We have very well-intentioned people who thought, we need to make sure these providers can support themselves. And rather than looking at the population health basis of, wow, when these providers are part of a multidisciplinary care team, they're able to really add value to a population health argument, what we found was that they were spending a lot of time trying to make sure they were doing billable services to cover their expenses, the way we all used to think about primary care. So part of my challenge is, how do I transition that fee-for-service mindset into what needs to be PMG 3.0, which is a more holistic population health-based mindset. When I got to Providence, I had the opportunity to begin working with our new PMG 3.0 initiative, which is looking at changing how we provide integrated behavioral health and primary care, among other things. And that's where we've chosen to really springboard our new staffing model for behavioral health. Initially, we went into this where you could have a provider in a clinic and they may be there 3 days a week, or you could have a provider shared between 2 clinics, or we would have one provider with 15 physicians. And we all know those resources those models don't work. Where Providence is going now is a ratio of about 1 to 6,000. That's our target, 1 to 6,000. And we're bringing that up through PMG 3.0. We'll be rolling out that ratio this fall in 3 of our clinics in the greater Portland area, which means that they'll have a psychologist and usually either a resident or an intern. In our bigger clinic that's in this trial, we actually have 2 psychologists and 2 interns, one of whom this year is so awesome, she's bilingual in a very impoverished Hispanic neighborhood. So we're really, really excited to begin not only bringing those up, but when we change to that different ratio, we're going to change the payment methodology. So instead of looking at the widget-based, here you go, you come in, you pay your copay, you see your primary care doc, and that's one charge. You see your behavioral health provider, and that's a second charge. It's going to be one inclusive cost for care, one inclusive alternative payment methodology that really allows us to remove the barriers so that our providers can meet patients where they are. Since I got here to Providence, one of my favorite things to do is to go out to the clinics and talk to the primary care providers, because they're the customers really at the end of the day that the behavioral health providers work with. And we've had a lot of opportunity to talk about what's working and what's not working. And that's really informed the development of PMG 3.0. Some of the concerns we've heard are things like double copays, inability to use some insurance products. We have providers who are restricted from practicing with mental health codes and doing mental health treatment. They always have to have a primary care diagnosis. So we wanted to look at how we could design a system that took care of their needs and addressed those needs, and then engaged them in how they would begin to change their practice to refer more people into integrated care. Some of our early successes have come in some of our smaller clinics. I have a behavioral health provider Dr. Dick Yeh out in Tannisbourne, who's just absolutely awesome. And he put on his wall on his whiteboard in his office that these hash marks of where he'll go in the morning and look over the doctor's schedules and say, hey, I've looked at some of your patients and I think I could be helpful in these 3 patients today if you want to call me in. We kind of call it bumpability, right? And he measures himself every day how many times those docs come and get him or call him up and say, hey, come in here and see this patient, or just bump into him in the hallway and say, hey, come in here. And he's been able to track how just by being out there and educating the docs himself, he's made himself more available. They're an early adopter clinic of great primary care engagement. The other key, though, for us is going to really be practice change coaches and physician coaches. As part of P&G 3.0, we're bringing in a family practice doc who's going to work with our 5 test clinics and really help teach the providers who they should be looking for to refer to the behavioral health provider. There's another piece of that project that's also interesting, though. One of the things we know that all primary care clinics have are very complex patients who are very, very difficult to deal with. Sometimes they're folks who are familiar faces in our ERs. Sometimes they're folks who just are always in need of something, and we never seem to be able to fulfill that need. And that's a drain on the whole clinic. So how can we support our clinics to take these patients and to work with them and get them to where they want to and need to be? Because as patients, nobody wants to be in that position either. It's not great to get your health care in the ER. So we're starting a behavioral health referral network that has a multidisciplinary team that will begin to take on collaborative patient case consultation, where in a structured fashion every week, we'll take the most complex cases from our clinics and have a team that reviews those cases, comes up with a care plan, and then works with the primary care clinic to be able to re-engage those patients and be there to be that support system for them. So when they're needing that little extra piece of help, it's not 5 and 6 phone calls, it's 1 phone call. And I think that's going to make a big difference for provider engagement in our model. Do we know how many people it's going to take to serve our entire system? No. We're starting with 5 clinics, 3 in the greater Portland area, 1 in Spokane, and 1 in Snohomish, Washington. And we know through the magic of telepsychiatry, we're going to be able to support those clinics in a very different way. And then as we begin to expand and spin this out to other clinics, that navigation center, which will be hubbed in Portland, Oregon, for the entire Providence system across all 5 states, that hub will begin to develop expertise that can support all of our Providence Health clinics and really begin to be that network of expertise that says, yeah, when you've got somebody you can't handle, we got this, and you know that. Providence Health System is really, really clear. We do 2 things really well. We want to be the best in the acute inpatient space, and that includes that subacute partial hospitalization layer, those types of very acute cases. And then we also want to be really good in the space of primary care. And the reason we chose those 2 levels of care as where our mission was because we know in Oregon we're very blessed to have a great community of providers who fill that more secondary realm, that ring of therapy, be it brief therapy or long-term therapy, outpatient services, ESA services, all those other types of things. So over the last few months, I've been working really hard to build out our relationships and partnerships with LifeWorks and Cascadia and with Western Psychological to really begin to figure out how we can behave differently, not only as a health system, but as a health plan, and engage them in caring for these patients. Great example, we're looking to start trialing some different ways of paying for those services from our health plan that includes reimbursing folks for keeping them out of the emergency department. How do we provide support to a Cascadia to enhance their services so that their patients don't end up in our ERs and that they can be more proactive as opposed to reactive? Those are the kinds of partnerships we're really interested in. I'm not interested in building out that space and labeling it Providence. I don't need to. We've got a lot of great providers and we need to support that community.